hospital medicine, and I have background in the heart failure. Did my fellowship from University of Texas at Houston in advanced heart failure and transplant cardiology. Over there and also here in Auctioner, we used to get a lot of viral myocarditis kind of picture, which would ultimately end up on our transplant list or on the list of left ventricular assist devices, which was, very rarely used. So we do get, in the setting of coronavirus, we do get these heart failure patients. And I think March 26th, JAMA Cardiology also published one case report, which is exactly similar to the one that we get in our center and also in centers around the country here in the United States. So I had a couple of things to say. I started up when this whole coronavirus pandemic started here in the United States. I was working from my home, on a telemedicine platform. And I started up seeing these patients. So by now, I think it's more than 400, around 400 to 500 cases that we have discussed on the online. And then I went to the hospital, kind of rounded on these patients on the floor and in the ICU. And then also, we had in our cardiovascular medicine team, we also had these kind of patients. So I just kind of quickly go briefly about the how all these things started up and what did we do and what happened to these cases. So in the month of February, we kind of heard about this thing coming to the United States, and we would definitely get these early symptomatic patients with like shortness of breath and some runny nose, like a typical flu-like symptoms, and we would check the vitals and everything. And if they would be fine, then we would just discharge them home. Because at that time we did not know what is the best strategy to put these patients on in terms of medications. Like later on we came to know about one trend, actually two different trends that we saw in kind of these patients, giving us a little challenge or curveball, is that these same patients which we discharged from the emergency room with mild symptoms, within 1 week, 7 days to 10 days, they came back with very, very severe symptoms. And their saturation, their pulse ox would be somewhere in the 80s, like 83, 85, and 86. And one particular pattern in these patients that we saw was that we would put these patients on the nasal cannula oxygen, and it would go all the way up to 10 liters per minute. And then after that, we would start these patients on non-rebreather, which is like 15 liters per minute, and they would deteriorate really fast, and then we would intubate them. Unfortunately, the hospital that I was working in, the mortality in the ICU reached to around 50% in the early days, but later on with these new medications and techniques like proning, and the ICU folks were kind of pretty much into it. So gradually the curve of our hospital mortality kind of flattened out. It's still not completely flattened, but it's at least not surging as
an associate professor of cardiology at KPMB. Thank you, Dr. Zahoor Khan. Excellent presentation about highlighting your experience. And this is exactly why we have this forum, to be able to share our experiences. There are very few, I would say, expert opinions on COVID-19. We're all in that learning phase and trying to learn every day from each other. So thank you very much for that. As far as the RAS inhibitors are concerned, the very short answer is that there is no data to suggest that we should stop ACE inhibitors and angiotensin receptor blockers. All of the European societies as well as the US societies recommendation is to continue for now. Now, obviously, if you have an hypotensive patient or a patient in shock, just like in any other patient, you will stop their antihypertensives, you will stop their ACE inhibitors, you will stop their angiotensin receptor blocker. That is a clinical decision. But per se, for COVID-19, the recommendation is to still continue. Thank you very much.
So Rizwan, please stay on for the next one or two questions. They also seem to be related
Sure.
to particularly cardiology, and then we'll ask Zahoor and other panelists as well. The question is that do COVID-19 patients develop biventricular failure or is it left ventricular failure? And so let me combine these because they are related to or maybe you can ask you can answer this question and we'll go to the next two cardiology related questions.
Dr. Khan, do you want to take that, or I can answer as well? So you go ahead.
You know, it's a very, very, very important and relevant question. At this point in time, what we have seen is Dr. Rizwan is here, and it's very, you know, kind of for me to talk in front of him is not befitting of me, but with his permission, I'm going to talk that the viral myocarditis, when it involves myocardium in general. However, because of the very nature of the myocardium, the most affected side is the left one. So we first see their manifestation, but the echo is nowadays, you know, it's very, very highly specific. I mean, highly super selected patient is, you know, selected for echo. So you can say that it's actually a biventricular failure, but what is the definition of this? It's a little complicated. So yes, I mean, I would say the answer is yes, but majority of the time, the manifestations are those of the left heart failure.
I agree. I agree with Dr. Khan that it is primarily patients that are having ARDS will come in with normal ejection fraction. As the ARDS worsens, you will start to see a significant reduction in their left ventricular ejection fraction, and it really goes down to very low numbers. And at that point in time, they have left ventricular dysfunction. Sooner or later, all of these patients will develop RV dysfunction because the most commonest reason for RV dysfunction is LV dysfunction. And as well as if you have significant pulmonary issues, you will have a RV strain pattern, you will have PA pressure issues. So sooner or later, it will become biventricular failure. So it very likely starts off as an LV dysfunction issue, but very soon becomes a biventricular issue. The other thing was about the myocarditis. All coronaviruses, this is the third major coronavirus that we have seen. The first one was SARS-CoV-1, the first SARS virus, which was a coronavirus. The second was the Middle Eastern respiratory virus, which was MERS. All of these coronaviruses gave rise to myocarditis. There are at least a few case reports now. One that Dr. Khan was referring to that came in JAMA Cardiology was also a middle-aged lady who presented with significant myocarditis. So yeah, certainly myocarditis is definitely something that we see in these viruses. And however, they could be perimyocarditis as well, just like in other viruses as well. Thank you.
Okay, very good. So next two questions I will combine into one. The question is, what biomarkers do we monitor for myocarditis? For example, troponin or BNP. And if we monitor BNP, what is the level, how high it can go in heart failure with COVID-19? So both Rizwan and Zahoor, one after another. Zahoor, you go first, please. Hello.
We use the BNP or NT-proBNP in the beginning. It usually in the setting of myocarditis-related congestive heart failure, it's in thousands. Like it goes beyond like 2,000 or 3,000 picogram per ml. And in some cases, like the one that was published in JAMA Cardiology on the March 27th, it went up all the way to 8,000 plus the pro BNP. But usually the pro BNP and the BNP, they have different numbers. So like BNP of more than 1,000 will be equivalent to pro BNP of around 2,000 or 3,000. So there is no, but we do see that these are in thousands. That's number one. And number two is that troponin is really super elevated. Like that kind of troponin elevation we usually see in the setting of a hyperacute or actually super acute MI, and in the setting of ST elevation MI. So if there is no ST elevation MI, rather the forces or the QRS complexes are really kind of with the lower amplitudes, and still the troponin is really high. So these two kind of combine to make a picture of viral myocarditis. Then once we have this picture, then we just basically focus on the heart failure management in general. And the heart failure management is guided more by the hemodynamics and by the volume status. And of course, they are both related to each other. So we don't necessarily follow the BNP or the pro-BNP level as a follow-up to kind of guide the therapy, but we just do day-to-day the volume status and the hemodynamic measurement. Because then after the diagnosis of viral myocarditis leading to congestive heart failure or cardiogenic shock, from that point onward, we focus on the hemodynamic recovery, basically.
Yes,
So, Rizwan, and then I'll give a chance to other panelists.
Sure. So I 100% agree. The only thing I would like to say is I have tried to stop myself from giving numbers or cutoff points, because nowadays there's so many assays. Different labs have their own assays. They have their own cutoff points. There is troponin I, there's troponin T. Both of them have slightly different cutoffs. Pro BNP and regular BNP, the ratio is usually 1 to 3. So pro BNP is much higher for the same patient. If you have one patient and you do pro BNP and BNP, the pro BNP has to be much higher, usually 2 to 3 times the BNP level, as Dr. Khan mentioned. So the troponin obviously has to be very high in myocarditis. There is that suggests significant myocardial damage. And I will just say this as well while I'm here, that troponin elevation and BNP elevation are associated with poor prognosis. Any signs of cardiac injury is associated with worse mortality and with worse morbidity, whether the patient is intubated or not intubated. So BNP, obviously, the higher the number, that is worse. And the management, as Dr. Khan mentioned, is pretty similar. Thank you.
Okay, thank you, Rizwan. Any of the other panelists?
Assalamu alaikum. My name is Dr. Samreen Safraz from Indus Hospital, Pakistan. In the past 2 weeks, we have had 5 expiries of severe COVID patients with ARDS. And our observation is that all of them, pretty much all of them, had troponins in the thousands with global hypokinesia. And it was like what I have to second what the other speakers were saying, because we are seeing patients with severe disease with a lot of raised troponins and pro-BNP, and they fare worse than others.
Thank you, Dr. Samreen. Any of the other panelists have any comment on these questions that have been discussed thus far?
So, this is Majid Shafiq, pulmonary critical care and interventional pulmonology doctor. Samreen Sarfraz asked an excellent question that I just answered within the Q&A chat box. I wanted to make sure others got a chance to hear that question and the response to that as well. She was asking the very pertinent question of allocation of scarce resources. And so whether or not, this sort of a situation has already arisen in the United States right now. We keep hearing about, of course, Italy and many other places as well. And if and when that does happen, is there some kind of a framework, a structure to that process? And the answer is, well, thankfully, that hasn't happened in the US thus far, although the New York State is dangerously close to that. They've converted dorms into patient care units, lobbies of hospitals, and so on, and they've made refrigerated trucks into morgues right now. But really, the demand hasn't quite outstripped supply yet. Though across the US, there is a well established framework called the quote unquote crisis standards of care. And there is good literature on that published by the Institute of Medicine. I put down a link to a document that they published about 10 years ago, keeping in mind the H1N1 influenza pandemic at that time. And that is the literature, the documentation that people are now quoting, going over. I know at my institution and other places as well, we are constantly looking into how are we going to have a just, fair, and equitable framework when the demand does outstrip supply, which by all indications is going to happen within the next 1 to 2 weeks. So I'd encourage others to look at this document as well. It might shed some light and give some ideas. I'm going to copy paste this into the chat box as well. Thank you.
Okay, great. Thank you, Majid. Now I see there's one question, I'll come back to that, but I would like to go to attendees who raised hand. And so there are two. First, I'll go to Dr. Moten and then Dr. Heriker. Dr. Moten, go ahead.
Assalamualaikum ji. This is Mariam Moten. I'm one of the cardiologists. Yes, we do see BNP elevation, and we also see pro-BNP elevation. The ratio in our hospital is 1 to 4. That's what I have been finding. I have seen 2 cases with biventricular failure with normal left atrial pressures, and the IVC is pretty small and collapsing, indicating that the person is hypovolemic. They're not volume overloaded. And the RV failure seems to be disproportionate to the LV failure. So it can be a biventricular failure, I have a feeling, but so far I haven't heard anything more about both the chambers getting involved, both the LV and the RV getting involved. And the other thing that somebody had mentioned about the elevation of troponin, yes, we have been seeing marked elevation in troponin, just like the other panelists like Dr. Rizwan Bhai and the speaker have mentioned. We have seen troponins going into very high numbers, prompting the patient to go to the cath lab. But it's a risk that all of us have to take sometime, and we are not sure if it's really a STEMI or is it something that's just a myocarditis that we are dealing with. There had been a couple of cases with endocardial involvement, and I'm not sure where we are headed with the endocardial involvement. Is it something that's going to be something like Loeffler's? I'm not sure. So those are my comments. Thank you so much.
Thank you. Dr. Heriker, would you like to go next?
Yeah. Assalamualaikum. I just wanted to make a very small point and then question about the multiple usage of a single vent. My point was that despite the troponins going very high, the LV has not been going down a lot. So it's been relatively, preserved LV as such. According to my observation, my question is, considering the ethical and the other issues that are related to persons going on, multiple persons being sent on one vent. So you see in places like Pakistan, Karachi, where we are thinking about training GPs and normal internists and people on using ventilators, when such things come up and we become, super excited about having multiple people on vent, do you think this should be practiced or even strongly thought about when we don't have that kind of expertise? In addition, the mortality rate of people on the vent is pretty high. So what benefit I feel is there when we are actually limited to having our settings made on the ventilator for multiple patients being on the vent? My third point was about ethical concerns. We're now thinking about actually So yesterday was a very bad night. We almost had a full, and we had restricted our emergency department on taking no more COVID patients. So do you think that now is the time that we select patients, and we've had our ethical board sit on it, that patients who are elderly, who may have a poor prognosis or bad comorbidities, we may need to think in those terms about conserving and putting the rightful people on the vent?
Thank you, Fawzia. I think the time, the preparedness is when the things have not happened. So that's my 2 cents common sense. But I would ask other panelists to address that. When is the time? What is the lag time? How far in advance you prepare for such situation where you have to decide between who gets the ventilator and those ethical questions?
I can answer those, excellent questions. I would completely echo what Dr. Shahid said. The time is now. Unfortunately, these are very difficult situations that nobody chooses. You only get forced into these situations, right? And when the time does come when demand outstrips supply, then whether or not you prepared for it, that is precisely what you would be doing. So the best thing to do really is to involve the ethical boards ahead of time. And as this document and other similar pieces of literature talk about, the best thing is to involve and make everybody feel empowered, involve other stakeholders as well, involve the community in these discussions. Definitely involve your house staff, your senior physicians, consultants, everybody, your nursing staff, etc., so that when the time does come, everybody feels that resources are being allocated in a truly equitable manner without any bias. Another important point could be, certainly this is something that we are trying to do in our hospital, that when and if that time does come, the person or the persons who are making those kinds of triage decisions are removed from the direct care of these patients. Because you don't want, the person who is, let's say, in the emergency room taking direct care of the patient and their family to be burdened with making an objective decision without any bias, implicit or otherwise. That's only human, right? So you have to have predetermined objective sets of criteria based on your, whatever prognostication you can do and such. You asked a really good question about using one vent for multiple patients. It's easier said than done, and almost every day I look at another one of those configurations and look at it with an open mind and ask myself, could that work? Would that work? To date, I haven't really seen a configuration that's very likely to work, because ultimately you're using one machine, and you might be splitting the forced air 2 ways, 3 ways, 4 ways, but ultimately you're going to be delivering the same FiO2, you're going to be delivering the same peak end expiratory pressure, the PEEP, and these are the 2 main determinants of treating hypoxia. And this is ARDS that we're talking about, hypoxic respiratory failure. Those are the 2 things you can't really change. There's many other things you can't change. So you really need to be very lucky and have a few patients that really have identical demands in most ways for this kind of an arrangement to work.
So just adding on to the question, should this ethical decision be made at triage? Is that the best place to do it, or after admission? Because we at triage, there and then in the ER, we need to decide about allocation of resources for a hypoxic patient. So if for instance, we make a cutoff of age 70 plus or 60 plus, or comorbids or functional status, what is the best place to make this decision?
I think I would say, the best place is the place that is mutually agreed upon by all of your local stakeholders. Again, no easy answers to these questions. Um, I think most people will also say this has to be something that is done on a rolling basis because people, people's conditions change dramatically sometimes, unexpectedly sometimes. We recently had one of our first COVID patients who was an 82-year-old lady with several comorbidities who got intubated and got extubated faster than any other COVID patient I've seen to date. She's happily discharged now. So you have whatever you do, I think there can be a starting point that has to be agreed upon by all the local stakeholders. So definitely the ER folks, but then also the inpatient folks and such. And there has to be a mechanism for continuing to reassess the patients and their clinical conditions. If you're going to be basing it, for example, on the troponin, well, what if the troponin cleared faster in 24 to 48 hours than you were expecting it to? So no easy questions, but your point's a very valid one.
All right. Any other panelists on this? I personally, sorry, go ahead. Who is this?
This is Dr. Abdul Hafiz. I'm a family physician in Manchester, UK. Just wanted to make a few comments in terms of few things which have been discussed, and obviously, as you know, UK is going through crisis at the moment, and there are some of the pertinent observations which we are making from here. First of all, I think there was a study published from China in Lancet earlier in March, I think 11th of March or something around that day, where they have actually indicated 4 markers which are associated with higher mortality. And they have been observing this on a regular basis. One of them was D-dimer levels, ferritin, LDH, and high sensitive troponin, cardiac troponins. So these are the 4 markers which they followed on all patients, and they observed that patients who are not, if these markers are not improving, then the outcome is going to be obviously mortality and so on. The majority of the patients which they put on ventilator, obviously 50% developed, more than 50% developed sepsis, and I think the mortality is around 50 to 60% in different centers. And the median admission in the hospital was 22 days in that particular study. Anyway, after having said that, in terms of preparedness for the crisis situation, obviously UK is going through that particular phase at the moment, and it is quite chaotic. The biggest issue which we are facing is the staff illness. Many of our doctors in emergency and intensive care units are down, either because they caught the infection or they are in self-isolation because they have a contact or family illnesses and so on. So when a situation like this arises, there is a shortage of the hospital beds, there's a shortage of hospital staff. Then obviously we need to think about preparing other staff members. For example, in UK now there is a training scheme going on, which is fast track ventilation or ventilator training of other specialties, for example, eye doctors and dermatologists. And I mean, these are people who never used these ventilators before, but they are actually preparing them for when the situation comes. Obviously, we are building some extra hospitals with the help of military in different cities, but there is no workforce, and the workforce has to be obviously pre-trained and to prepare for that situation. But obviously there are a lot of rational decisions, a lot of thinking which we are obviously discussing here will not apply, and then everybody has to just make a clinical decision or a judgment on the spot, which is not that easy. But obviously this is what happens when you are going through a crisis. In terms of choosing a patient, which one should you be offering or putting your resources? I mean, in UK, we are using Ferrelli score, which is obviously advised by NICE, as well as comorbidities. So these are the 2 main things which the team, I think we have a team of 3 doctors in each of the centers who are allocated that responsibility. So they look at the whole situation and then decide if ventilator is available, then who is going to get it. And on the other side, a patient who is on ventilator, and if the clinical markers which I've described before, and there is no sign that there is any improvement or things are getting worse, then after 3 weeks of ventilation, they are making the decision that obviously we should now stop ventilation and offer this ventilator to another person. Thank you.
Thank you. I see that if other panelists, Asma Chima or our guest from Peshawar, Niaz Ali, have a comment. So please go ahead.
Yes, thank you very much for giving me that point. I report a question to Dr. Zahoor. Yes, the receptors are different regarding SE inhibitors, but logically speaking, the clinical outcome that is there in shape of ADR, like persistent dry coughing and angioneurotic edema, which are the most adverse effects of the SE inhibitors. So though the receptors are different, but yet they are adding on to the ultimate clinical scenario of the patient. So is it not suitable that per time being removed from SE inhibitors shift to other, because there are a lot of options for antihypertensive drugs?
Dr. Zahoor.
Niaz has been my teacher in Peshawar, if he was the one who was working at RMI. So with our due respect, I was reading a detailed study which was published on American Medical Association website in regards to the ACE inhibitor issue. So they kind of bring this logic of what is the difference between ACE1 and ACE2 inhibitor in regards to whether or not there is any contribution of using the ACE inhibitors in population at this specific point in time in human history. So they say those patients who are on ACE inhibitor for hypertension or for ischemic heart disease, or we also use ACE inhibitor in our primary care setting by default, who is any person who is diabetic and in order to protect the kidneys, those patients are also put on ACE inhibitor. They say with these patients, the data shows that basically the ACE2 inhibitors are downregulated with age automatically. It has nothing to do with the ACE inhibitor utilization because they work on type 1. The young patients, the young folks who are under 40, and in that specific article, which is still there on the American AHA website, it says that those patients who are under 50, basically the ACE2 inhibitor is upregulated in those patients, in those population. Those patients who are on the ACE inhibitors, they are usually above 40, and most of the time they are above 50. So even if we discontinue ACE inhibitor in these patients, age has already downregulated their ACE2 inhibitors, their ACE2 receptors. So that is the rationale behind their not letting the ACE inhibitors off the market at this point in time. But you're right, your concern is very, very right. In saying that why we are taking risk if there is involvement of this receptor, and it makes sense when you inhibit type 1, then there is a upregulation of type 2. Then we're actually putting oil on the fire by allowing these ACE2 receptors to be upregulated. But they kind of give the data and the rationale that with these patients who are on ACE inhibitors, their ACE2 expression has already downregulated with age.
Thank you. Let me go to the last few questions as we are coming to the close of time. And these questions are concerning about because also we have seen about the ethical questions. So what are the indicators which suggest a better overall prognosis? That's a more general question. So let's answer that, then there are 2 or 3 other questions. Dr. Zahoor, if you would like, and then any other panelists.
Sure, sure, absolutely. This question is particularly pertinent to cardiovascular or in general to the COVID manifestation?
You can answer it in both ways, if you can.
As I said in the beginning, young folks will fare really well. And as the pandemic started, we observed this, that basically those patients who were 60 plus, and then later on, this number came down to 50 plus, and now we are putting down this bar down to 40. Those patients who are young, they're actually faring really well. This irrespective of how they present. I have seen myself, a patient, like one of our pulmonologists has rightly mentioned that one of their patients discharged and he did really well unexpectedly. And I have seen young folks, and I still have those images, x-rays, images with me, I can show it, that patient was extubated. He was around 38, African-American. He was extubated because his oxygenation was really good. And his x-ray was still looking very terrible. The x-ray findings were like, if we follow up x-ray day-to-day basis, so x-ray was really terrible. So what we kind of concluded from that particular patient was that he did not have any other comorbidities, number one. And number two, his work of breathing, his overall body habitus kind of let the dead space to be completely utilized, because the dead space sometimes work in these kind of situations when the lower parenchyma is involved and that upper space is kind of utilized. So there was one theory behind their specific patients, but we can't extrapolate anything at this point in time because we don't have a large study on clinical as well as on a basic side. So number one, young folks really do well. Number two, with non-cardiac patients, these other 4 parameters that one of our colleagues from Manchester mentioned, that was published in Lancet. Those parameters are also considered in different levels in regards to their quantification. The lower their quantity, the better their prognosis. The higher their quantity, the poorer is the outcome. So LDH and ferritin, and the other 2, actually they're coming, and I'm blanking on it, I'm sorry for that. So it's not necessarily that just mere positivity is important for that. Their quantification is also important, like if they're 10, 20, 30, or 40. So the lower the number, the better the prognosis. This is what that study has said, and this is what we have seen here, but we can't extrapolate our numbers here. When it comes to the cardiac side, like this one particular case that was published in JAMA Cardiology, their numbers were pretty bad. Their protein P was like 8,000 plus, the troponin was sky high, and that patient was managed not necessarily for the COVID, but that patient was managed with the inotropic support, and at some point in time there was a volume replacement, and the one antiviral and one antimalarial was added to his regimen. So that patient really did well. So at this point in time, the data is so limited that one cannot, put one's money on a specific scoring system or a general statement to kind of make sure that, okay, if someone is having these parameters, then they're going to fare well. But generally, young folks really fare well.
I see Abdul Hafiz, if you had any comment on this.
I think I'll just make two observations, which obviously I would like to share from here. Obviously, the question is put in a very interesting way. All studies, I think, are looking at negative outcome markers rather than positive outcome markers. However, in the UK, another observation which we are making is generally the medics, or clinical staff or non-clinical hospital staff, which suffer from this disease, have a poorer outcome, which probably is related to viral load. General public, obviously, when the places they catch the infection is not as high concentrated compared to hospital environment where viral load is much higher, and these are the people who this group actually overall does bad in terms of the outcome. The other observation which we have seen some of these patients who have, proven COVID. They have low SATs, but they appear well. So the patient might actually be sitting and chatting with you, but when we put the probe on, the SATs are running very low. And obviously then we do ABG, and even arterial blood gases are quite low as well. This is an interesting phenomenon. Normally when SATs are low, people get confused, but there is something going on which we haven't been able to figure out as yet. But obviously this is what it is.
I see that Dr. Majid have put on the chat some of the, Majid, can you briefly discuss if there's a more solid criteria for prognosis, or is it still a work in progress?
Thank you, Dr. Shahid. Yeah, I would say, it's obviously we are struggling to learn more and more about this disease every passing day. And I think that study from China was very useful that, one of us just quoted, but it was still, mostly retrospective, just a single center, all those caveats, right? And now there's more, we're learning at our institution, we're gathering data as we go along, and it seems like CRP seems to be a particularly poor prognostic indicator, but these are, you have to take them with a grain of salt. We don't have good multi-center prospective data. By the time we have it, the pandemic will inshallah be over. So this is the best that we have right now. I just wanted to share this particular URL, covidprotocols.org. My institution came up with this, and it's all the credit to our trainees, our fellows, who are working day and night to scour through all the reams of literature and keep updating our understanding of various aspects of COVID management, including the section on prognosis as well, in case it's of any help. But again, remember, the data is very sketchy right now.
All right, let's finalize the last few questions, I think 2 or 3, and then we'll wind up today's session. One is that, is there any role of CRP and ESR? And along with that, I would put in the second question that, is there a role of PYP scan in these patients? So anyone, Dr. Zahoor, starting with you, and then any panelist?
For the sake of, for the sake of initiation, treatment protocols is per our ER and per our hospital. We basically go day by day and just go to the clinical picture of the patient. So we do see patients where, as I mentioned earlier, the objective data of imaging and chemistry is really bad when we compare to our previous viral myocarditis patients, like in any other day other than the pandemic. And they're doing well. At the same time, as I mentioned, we just right now we just go by clinical improvement, and there is no clear-cut number which we can correlate with the clinical recovery when it comes to the objective data. So I would say, I'm really humble to answer this in concrete terms.
Any of the panelists know any data as to the utility of these inflammatory markers, as well as this scan, PYP scan? And in addition, there's a question about X-ray findings. How do they lag behind the clinical scenario? And if yes, how much?
I mean, I would talk about the X-ray finding because that's my, I would say it's not my forte, but I would definitely put my money on this. The X-ray findings are, basically way ahead of clinical manifestation. This is what I'm observing. Even with the GI patients who are coming only for nausea and vomiting, and you just do the X-ray by accident, just because now this is becoming a, you know, a reflex action. You see a bad X-ray and you'll be surprised that, look at this X-ray, look at this gentleman. It's like, and look at his symptoms. He's not even talking about cough. He's not talking about shortness of breath, but look at this bad X-ray. Same goes for the CT scan. We did a CAT scan for gastro. We were actually kind of doing the CAT scan with a thought process that this patient might have some kind of GI thing like diverticulitis or, you know, stuff like that. Let's rule out colitis. He did not even have nausea and vomiting. He was just like a profuse diarrhea and very, you know, very tender abdomen. And believe me, just those lower segments of the lungs, which were captured by the CT abdomen and pelvis, they were ground glassed. And then when we went ahead, just did the X-ray, X-ray was like, so it's X-ray findings are way ahead of clinical manifestation, I would say.
Right, right. So it is opposite of the question, which
it's totally the opposite.
it seemed like that it suggested that they lag, but they are way ahead.
They are way ahead.
Findings.
X-ray findings are way ahead. So in other words, the pulmonary infiltrates are way ahead of time. So, and they're pretty significant. If you would take that X-ray out of this pandemic and put it in any other time in point in time, then you would definitely find a patient who is either, you know, having multifocal pneumonia, or he's having like, you know, pulmonary edema, or he's coming with the, you know, acute on chronic heart failure exacerbation or something like that. And these folks just walk in the ER and they say, "Doc, I feel like I have some kind of weakness and I don't feel well." And when you do their chest X-ray, they look really bad. So I'm not really sure if it's the same thing happening with my other colleagues, or it's just me. I'm seeing this paradox.
Any other comments from the panelists?
Yeah, I think this is Abdul Hafiz. I think we are seeing the same, you know, observation. I think it's been reported from other centers as well. You know, bilateral pneumonia is a classical, you know, characteristic finding which has been reported with COVID.
So at least we have one, you know, chest X-ray, which is a very simple evaluating, you know, thing. But what about other, you know, like PYP scan? I didn't get the answer for that, and personally do not know about it. And then how about the renal system or hepatic system? How do that get involved, and how much is the lag time? Do they get involved earlier on or later?
Can I respond to that?
Yes.
Yeah.
Yep.
So
yep.
the renal involvement is definitely there, particularly in my heart failure patients. It's like, you know, it's like they're talking to each other all the time, kidney and heart. However, from what I saw, those patients, my African American patients, like four of these patients, I had to put a dialysis line in them after we intubated them, because within 24 hours, their creatinine went up to like 8 and 10. And they became completely shut down on us. They did not have any chronic kidney disease, or maybe they had it, now they're getting unmasked. But the idea is that there is definitely involvement of the kidney system, whether it's a cardiorenal physiology or it's a direct involvement of the kidney tubules, because they're also kind of the same. When you look to the epithelium of the kidney tubule, and also the mesothelium, the epithelial cells of the inner lining of the alveoli, or the you know, those you know, segments of the lungs, they, you know, they're after all epithelial cells. So whether there is a direct involvement, like Dr. Wooten said, there is involvement of the endocardium as well. So that needs to be studied. And this kidney involvement needs to be studied because it's pretty dramatic. I think I have seen a lot of cardiorenal syndrome patients. The progression of kidney failure is not that dramatic, usually in the cardiorenal syndrome patients. My other cardiology colleagues would agree to that. But in this particular situation, I have seen 4 patients which we intubated. They deteriorated really fast on the floor on us. We had to intubate them and transfer to the unit. And within 24 hours of their intubation, we had to put the dialysis line in them, all 3 on their side. That was like my line night. So, I definitely see there is an involvement, and I do believe that there is a direct involvement of the virus itself, of the kidney tubules, needs to be studied.
Okay, great. I think this would be the last question of today's session. Is there a role of echocardiography and the role of myocardial strain evaluation by echocardiography in these patients? Dr. Zahoor?
As I said, like many of our echo tech are not even coming. So we have reduced the use of echo to very super selected patients, which we really want to assess like Dr. Wooten says, the IVC, because in these patients, we have to be very, very meticulous in volume management. If the IVC is really dilated, then we have to go one way, or if they're collapsing, then we have to go the other way. And that's sometimes the only way to kind of assist. And that I do myself on the bedside, but it's yet to be. I mean, these are all very, very important and interesting questions. But usually, I mean, I would say leave it to the senior cardiologists here. They would talk more.
So far you're going with this other markers of the strain rather
Yes,
than
sir.
going for echocard, and
Yes,
those
sir.
will be troponin and others. Okay. Any of the panelists last comments, questions, so that we are going to wrap it up now? Any?
This is
Yes,
Dr. Abdul. Dr. Abdul.
Yes.
Dr. Abdul Hafiz. The classical situation which happens with these patients, day 7 and day 10, or anywhere in between, is quite a classical time when the deterioration actually happens. So usually these patients present with minor symptoms, and then later on, obviously, the body's defenses kick in. And a particular marker which I actually attributed to lung damage and as well as part of the body is cytokines. The cytokine storm, which is actually trying to destroy what indirectly actually damages the body. So this is obviously, I think, the tissue damage in the alveoli, micro thrombus formation, the small vessels, as well as obviously similar cytokines might causing damage in the kidney as well. However, from kidney point of view, patients, we are actually trying to keep these patients, especially who are on a negative fluid balance. And obviously, just by the basic fact that if there is more fluid in the body, it will obviously accumulate more within the lung tissue and cause further hypoxia and obviously poor outcome and so on. So that's why that in the beginning we were using quite intense negative balance, not giving fluid, and probably using some diuretic as well to get some fluid out of the body. Actually, later on, this is obviously not a big data, but the observations were, and this was sudden, deterioration in kidney functions. So now we are using a little bit of less aggressive approach, just fluid deprivation rather than the use of diuretics and so on.
Okay, great. Thank you, Dr. Hafiz. Any of the other panelists, last comments? All right. So I think we would like to now close. It's 15 minutes above the time. And again, once again, I would like to thank you, our speaker, Dr. Zahoor Khan, our panelist, Abdul Hafiz, Majid Shafiq, as usual, Niaz Ali, especially from Pakistan, Peshawar, Samreen Sarfraz from Karachi, India, and all of the attendees. Without your great questions and without the great participation of the panelists and the speaker, this program would not have been successful. So I really appreciate your participation. Please keep coming back. We are circulating the dates for the next 2-3 weeks. So please indicate your availability as a panelist or a speaker so that we have a good schedule for the next 2 weeks. Thank you very much. Assalamu alaikum.
Thank you very much for having me, Dr. Shahid, and I apologize for a little technical
No problem.
difficulty in the beginning.
Thank you. Assalamu alaikum.
Assalamu alaikum.